more of the same won't fix general practice. But what will? My new book, Medical Generalism Now, describes why, and most importantly how, advanced generalist medicine must be part of the solution. This is the second of my short videos introducing some of the key ideas that I cover in the book. I started looking at access. Today, I'm going to take a look at the issue of healthcare burden. Modern healthcare is astounding. We can do so much to tackle and even sometimes reverse the biomedical disruption that results from disease processes. But in Western communities, people are now living longer, but with more chronic degenerative illness that affects every organ system: hearts, lungs, musculoskeletal, neurological, endocrine. We can do ever more to try and manage and mitigate those degenerative effects. But the unintended consequences of our efforts is that healthcare is now becoming part of the problem. A recent review in BMG Open looked at the workload facing a typical older person living with 6 common chronic problems. A patient following guideline-defined best care for each of those conditions would be taking at least 13 medicines a day, attending up to 6 appointments a month, and spending around 20 hours a week on health-related activities, like managing medicines, self-monitoring, getting lab tests done, making lifestyle changes. That's half a full-time job. 40 years ago, researchers began to describe how a chronic illness disrupts and burdens our everyday living, our everyday life. Today, our research, and indeed our clinical experience, is starting to reveal a new type of disruptive effect: the burden of living with medical disease management. It's this emerging phenomenon of treatment burden which has been a significant driver behind the resurgence of interest in medical generalism. Medical generalism is the expertise of whole person medical care. How do we treat the person, not just the disease or diseases that they have? So generalist practice looks explicitly at if and how medical care can improve health for daily living. Healthcare is a means to an end, not the end in itself. I've been studying medical generalism for over 20 years, and people have been writing about it for far longer. And whilst everyone agrees the focus is on whole person care, in contrast to the condition or organ-specific practice of specialist medicine, after that it gets messy. Because unlike for specialist medicine, there isn't a clear account of how, in practice, medical generalism works on the ground. So let's take a closer look. Specialist medicine is grounded in the principles and practice of evidence-based medicine. Evidence-based medicine describes the scientific model we use to make sense of illness and disease, and so to guide medical care. You'll be familiar with the concepts of hypothetico-deductive method and using statistical methods to describe the probability and precision of different outcomes. There's a commonly held misunderstanding that generalist medicine is just more of the same. The generalist has been described as a jack of all trades, someone who knows a little bit about a lot, who can do the easier or routine bits of specialist medicine and refer the rest on. We certainly need capacity to deliver routine specialist care within our healthcare systems. Indeed, this is the focus for our new integrated care systems, using both extended workforce and digital solutions to try and deliver more of the same. But this isn't advanced generalist medicine. Integrated, scaled up, routine specialist medicine isn't the expertise of advanced generalist medicine. And it isn't going to tackle the challenges facing our creaking health system, and it isn't going to help someone like Alice. Alice is a typical patient I see in everyday practice, and I'm sure you do too. She comes to see me because she's feeling exhausted. Not just a bit tired, but overwhelmed, unable to carry on with her normal everyday stuff. Alice is in her 70s. She lives with multiple long-term conditions: diabetes, hypertension, arthritis, depression. She's one of those people we've got doing 20 hours a week of work to juggle all her healthcare demands. But she also has a family, a house to run, friends, social groups she supports and is supported by. So how do we, as advanced generalist practitioners, help Alice? Well, clearly evidence-based guidelines, however well coordinated, isn't the answer to providing care here. They don't help us to work with Alice to juggle the completing pressures that come from her illness, her diseases, her medical care, and her daily life. When we work with patients like Alice, we use a much wider set of resources to guide our practice. Yes, we use the guidelines and data from evidence-based medicine, but much, much more. We also use Alice's expertise, her story of daily living and of managing her health. We use our own professional knowledge and experience of local services and local options. The distinct expertise that we use in advanced generalist medicine lies in our ability to critically use what we know to work with Alice to create a tailored understanding of what is wrong, put a healthcare plan in place, and then critically examine if and how the plan has helped, revising it if we need to. This isn't just simple evidence-based medicine at scale. It doesn't rely solely on the knowledge from researchers distilled into guidelines being applied in practice. Instead, it is a model of professional practice which critically creates new knowledge in context. But it's not the opinion-based medicine described and criticised in evidence-based medicine. Instead, it's a distinct form of scientific practice and reasoning which allows the advanced generalist practitioner to systematically explore, explain, and evaluate whole person illness, and so generate a critical, robust understanding of illness in context. In medical generalism now, I describe the 4 E's of advanced generalist practice, the knowledge work needed to explore, explain, and evaluate whole person illness. The 4th E is the principle which distinguishes this work from opinion-based medicine. It's the epistemological expertise that helps us to understand the trustworthiness or quality of our scholarship and our beyond guideline decision-making. This epistemological approach is based on a scientific principle of inductive reasoning, in contrast to the hypothetico-deductive reasoning of evidence-based medicine and specialist medicine. The science of advanced generalist medicine relates to the qualitative tradition of research, just as specialist medicine relates to the quantitative tradition. And good medical practice, like good research, needs strong examples of both. I've been a GP for 22 years, and at the same time, I've worked as an academic, training in and using the inductive reasoning to generate scientific evidence. These skills are also what enable me to safely deliver advanced generalist medicine in my everyday clinical work. But other GPs have told me, informally and in my research, that their own professional training hasn't allowed them to develop those skills and crucially develop the confidence they need for advanced generalist practice so they can help people like Alice. So I've been working to change that. In the Catalyst programme, Wise GP and the Wisdom course, we're changing professional training. But crucially, we're also evaluating the impact of those changes, showing that we can improve the skills and confidence of frontline GPs. In other projects like Taylor, Times and Bounce Back, we're looking at how we can change the practice settings in which people work in order to better support and sustain this complex model of advanced generalist practice. And I discuss all of these in the book, including what it all tells us about the future changes to healthcare that we need. Specialist and generalist clinical reasoning are the yin and yang of medical practice. We need both in modern healthcare, but that means strengthening advanced generalist practice. In my next video, I'll outline the key steps I recognise in medical generalism now as necessary to achieve just that.